Acne vulgaris is a chronic inflammatory skin condition affecting mainly the face, 99% of cases, back, 60% of cases, and chest, 15% of cases. Acne is characterized by blockage and inflammation of the pilosebaceous unit, the hair follicle, hair shaft, and sebaceous gland. It presents with lesions which can be non-inflammatory, inflammatory, or a mixture of both. Non-inflamed lesions are known as comedones, which may be open, blackheads, closed, whiteheads, or microcomedones, clinically invisible. Inflammatory acne lesions include papules and pustules, 5 millimeters or less in diameter. In more severe disease, these can develop into larger, deeper pustules, nodules, or cysts. Most people with acne have a mixture of inflammatory and non-inflammatory lesions. Conglobate acne is a rare and severe form of acne found most often in men. It presents with extensive inflammatory papules, suppurative nodules, which may coalesce to form sinuses, and cysts on the trunk and upper limbs. Acne fulminans is a sudden severe inflammatory reaction that precipitates deep ulcerations and erosions, sometimes with systemic effects, such as fever, arthralgia, and myalgia. Neonatal acne can be present at birth or can develop after delivery, generally before the child reaches 6 weeks old. It is typically characterized by papules and pustules on the forehead, cheeks, and or nose, and is expected to resolve spontaneously in a few weeks to a few months. Classification. There is no universally agreed grading system for acne, but it is often categorized by lesion type and severity into mild acne, predominantly non-inflamed lesions, open and closed comedones, with few inflammatory lesions. Moderate acne, more widespread with an increased number of inflammatory papules and pustules. Severe acne, widespread inflammatory papules, pustules, and nodules or cysts. Scarring may be present. Causes. The pathogenesis of acne is not completely understood, but is thought to involve several processes including altered follicular keratinocyte proliferation leading to formation of follicular plugs, comedones. Androgen-induced seborrhea, increased sebum production, within the sebaceous follicles which usually occurs around puberty. Proliferation of bacteria, such as Cutibacterium acnes, formerly known as Propionibacterium acnes, within sebum and hair follicles. Inflammation of the pilosebaceous unit. Studies have suggested that other factors may contribute to the pathogenesis of acne, such as genetic factors, a high concordance between identical twins and a tendency towards severe acne in people with a positive family history has been identified. Racial and ethnic factors, the prevalence, severity, clinical presentation, and sequelae of acne varies between different population groups. Diet. Recent studies suggest there may be a correlation between acne and high glycemic index diets. Other foods inconclusively linked with acne include milk and whey proteins, and dairy or meat products high in leucine. While diets including sufficient levels of omega-3 fatty acids and gamma-linoleic acid may be associated with reduced acne lesions. Hormonal factors. Females with acne may notice increased eruptions slightly prior to or in the first few days of their menstrual period. Additionally, people with endocrinological disorders including hyperandrogenism or polycystic ovarian syndrome may develop acne. Complications. Scarring. Acne may result in hypertrophic or atrophic scars which can be extensive. Keloid scar tissue development has been reported to be 5 to 16 times more common in people with darker skin types. Post-inflammatory hyperpigmentation or depigmentation can occur. This may be more common in people with darker skin types, the etiology of which is currently unclear. Psychosocial effects. Acne is associated with significant psychological problems including an increased risk of depression, suicide, anxiety, reduced attachment to friends, and low self-esteem. Systemic comorbidities. Acne is closely associated with several systemic comorbidities, including obesity, diabetes mellitus, hyperlipidemia, hypertension, and metabolic syndrome. Prognosis. Acne usually starts at puberty and resolves as adolescence ends. Persistent acne can last into adulthood for a smaller number of people. A smaller proportion may experience acne for the first time in adulthood. Acne is a chronic disease that can persist for many years. It tends to affect adolescents and usually resolves after the end of growth. Males may be more likely to experience severe acne, and severe acne can be more persistent. It may persist into adulthood as a continuation of adolescent acne or due to development of late-onset disease. Females are more likely than males to have acne in adulthood. Estimates indicate that acne may persist in up to 5% of affected females between the ages of 40 and 49. The predictive factors for persistence into adulthood are not clear. Diagnosis. Clinical features. Take a history asking about duration, type, and distribution of lesions. Previous treatment, including over-the-counter medications, and response. Exacerbating factors such as flares with menstruation, contraceptives, cosmetics, face creams, or hair pomades. Systemic features. Some rare subtypes of acne, acne fulminans, can present with systemic features including fever, arthralgia, and myalgia. Psychosocial impact of acne. Ask about psychological problems including anxiety and low mood. Family history including endocrine disorders, polycystic ovarian syndrome, acne, and other skin conditions. Possible underlying causes. Drug history. Some medications can cause or exacerbate acne-form rashes including androgens, corticosteroids, isoniazid, cyclosporin, and lithium. Hyperandrogenism may present with irregular periods, androgenic alopecia, or hirsutism in women. Examination. Comedones must be present for a diagnosis of acne to be made. If not present, other diagnoses should be considered. Record the type and distribution of lesions and severity. Look for signs of other disorders that can present with acne such as hyperandrogenism or polycystic ovarian syndrome. Suspect acne in a person presenting with non-inflammatory lesions, comedones, which may be open, blackheads, or closed, whiteheads. Inflammatory lesions such as papules and pustules, superficial raised lesions, less than 5 millimeters in diameter. Nodules or cysts, larger than 5 millimeters in diameter. Deeper, palpable lesions which are often painful and may be fluctuant. In very severe acne, nodules may track together and form sinuses, acne conglobata. Scarring, atrophic/ice pick or hypertrophic/keloid scars may be seen. Pigmentation, post-inflammatory depigmentation or hyperpigmentation may be present. Seborrhea, commonly present. Differential diagnosis. The differential diagnosis for acne includes rosacea, perioral dermatitis, a relatively common chronic inflammatory skin eruption which presents around the eyes, nostrils, mouth, and occasionally the genitals. Most common in lighter-skinned, young to middle-aged women, 20 to 45 years. Folliculitis and boils. Drug-induced acne. Some drugs can cause or exacerbate acneiform eruptions including dioxins, chloracne, corticosteroids, anti-seizure medications, phenytoin, carbamazepine, phenobarbital, valproate, lamotrigine, levetiracetam, and oxcarbazepine, lithium, isoniazid, cyclosporin, vitamins B1, B6, and B12, and anabolic steroids. Keratosis pilaris, a very common, dry skin condition caused by keratin accumulation in the hair follicles, and is typically found in children and young adults. Management. Advice. Advise the person to avoid overcleaning the skin, which may cause dryness and irritation. Acne is not caused by poor hygiene. To use a non-alkaline, skin pH neutral or slightly acidic, synthetic detergent cleansing product twice daily on acne-prone skin. To avoid oil-based comedogenic skincare products, makeup and sunscreens, and if makeup is used, it should be removed at the end of the day. That persistent picking or scratching of lesions can increase the risk of scarring. That treatments may irritate the skin, especially at the start of treatment. To reduce the risk of skin irritation associated with topical treatments, start with alternate day or short contact application, for example, washing off after an hour. That there is not enough evidence to support specific diets for treating acne, but provide advice on how to maintain a healthy diet. When discussing treatment choices with a person with childbearing potential, cover that topical retinoids and oral tetracyclines are contraindicated during pregnancy and when planning a pregnancy, that they will need to use effective contraception or choose an alternative treatment to these options. Treatment: mild to moderate acne. For people with mild to moderate acne, offer a 12-week course of one of the following first-line options to be applied once daily in the evening. A fixed combination of topical adapalene with topical benzoyl peroxide, 0.1%, or 0.3% adapalene with 2.5% benzoyl peroxide. A fixed combination of topical tretinoin with topical clindamycin, 0.02, 5% tretinoin with 1% clindamycin. A fixed combination of topical benzoyl peroxide with topical clindamycin, 3% or 5% benzoyl peroxide with 1% clindamycin. Consider topical benzoyl peroxide as monotherapy as an alternative if these options are contraindicated or the person wishes to avoid using a topical retinoid or an antibiotic. Creams or lotions may be preferable for people with dry or sensitive skin, and less greasy gels may be preferable for people with oily skin. Concentration or application frequency of topical treatments may need to be reduced or lowered if skin irritation occurs. Advise the person that frequency of application can be gradually increased from once or twice a week to daily if tolerated. Treatment of moderate to severe acne. For people with moderate to severe acne, offer a 12-week course of one of the following first-line options. A fixed combination of topical adapalene with topical benzoyl peroxide to be applied once daily in the evening. A fixed combination of topical tretinoin with topical clindamycin to be applied once daily in the evening. A fixed combination of topical adapalene with topical benzoyl peroxide to be applied once daily in the evening, together with either oral limacycline 408 mg or oral doxycycline 100 mg once daily. Topical azelaic acid, 15% or 20%, applied twice daily, with either oral limacycline 408 mg or oral doxycycline 100 mg once daily. Consider topical benzoyl peroxide as monotherapy as an alternative if these options are contraindicated or the person wishes to avoid using a topical retinoid or an antibiotic, oral or topical. For people who cannot tolerate or have contraindications to oral limacycline or oral doxycycline, consider replacing these with trimethoprim or with an oral macrolide, for example, erythromycin. Combined oral contraceptives, if not contraindicated, in combination with topical agents can be considered as an alternative to systemic antibiotics in women. Oral progesterone-only contraceptives or progestin implants with androgenic activity may exacerbate acne. Third and fourth generation combined oral contraceptives are generally preferred. Cosaprindiol, Dianet, or other ethinylestradiol/cyproterone acetate-containing products may be considered in moderate to severe acne where other treatments have failed but require careful discussion of the risks and benefits with the patient. Use should be discontinued 3 months after acne has been controlled and prescription guided by the UK medical eligibility criteria for contraceptive use and the summary of product characteristics for the individual product. Follow-up. Review first-line treatment at 12 weeks to assess whether the person's acne has improved and whether they have any adverse effects. In people whose treatment includes an oral antibiotic, if their acne has completely cleared, consider stopping the antibiotic but continuing the topical treatment. Improved but not completely cleared, consider continuing the oral antibiotic alongside the topical treatment for up to 12 more weeks. Only continue a treatment option that includes an antibiotic, topical, or oral for more than 6 months in exceptional circumstances. Review at 3 monthly intervals and stop the antibiotic as soon as possible. If acne has cleared, explain that maintenance treatment is not always necessary. Consider maintenance treatment in people with a history of frequent relapse after treatment. Consider a fixed combination of topical adapalene and topical benzoyl peroxide. If this is not tolerated, or if one component of the combination is contraindicated, consider topical monotherapy with adapalene 0.1%, azelaic acid 15% or 20%, or benzoyl peroxide 5%. Review maintenance treatments for acne after 12 weeks to decide if it should be continued. If acne fails to respond adequately to a 12-week course of a first-line treatment option, and at review the severity is mild to moderate. Offer another treatment option. Moderate to severe, and the treatment did not include an oral antibiotic. Offer another treatment option that includes an oral antibiotic. Included an oral antibiotic. Consider referral to a consultant dermatologist-led team. If mild to moderate acne fails to respond adequately to two different 12-week courses of treatment options, consider referral to a consultant dermatologist-led team. If a person is taking oral isotretinoin for acne, review their psychological well-being during treatment and monitor them regularly for symptoms or signs of developing or worsening mental health problems or sexual dysfunction. Tell the person to seek medical advice if they feel their mental health or sexual function is affected or is worsening, and to stop their treatment and seek urgent medical advice if these problems are severe. Relapse. If acne responds adequately to a course of an appropriate first-line treatment but then relapses, consider either another 12-week course of the same treatment or an alternative 12-week treatment. If acne relapses after an adequate response to oral isotretinoin prescribed under specialist care and is currently mild to moderate, offer an appropriate treatment option. Moderate to severe, offer either a 12-week course of an appropriate treatment option or re-referral if the person is no longer under the care of the consultant dermatologist-led team. If acne relapses after a second course of oral isotretinoin prescribed under specialist care and is currently moderate to severe, further care should be decided by the consultant dermatologist-led team. If the person is no longer under the care of the consultant dermatologist-led team, offer re-referral. Referral. Urgently refer people with acne fulminans on the same day to the on-call hospital dermatology team to be assessed within 24 hours. Refer people to a consultant dermatologist-led team if there is diagnostic uncertainty. They have acne conglobata. They have nodulocystic acne. Fully inform the person and their family and carers as appropriate about the potential risks of isotretinoin treatment as well as the expected benefits before referral to the consultant dermatologist-led team, and again before prescribing isotretinoin if that is the chosen treatment. Consider referring people to a consultant dermatologist-led team if mild to moderate acne has not responded to two completed courses of treatment. Moderate to severe acne has not responded to previous treatment that includes an oral antibiotic. They have acne with scarring. They have acne with persistent pigmentary changes. Their acne of any severity or acne-related scarring is causing or contributing to persistent psychological distress or a mental health disorder. Consider referring people to mental health services if a person with acne experiences significant psychological distress or a mental health disorder, including those with a current or past history of suicidal ideation or self-harm, a severe depressive or anxiety disorder, body dysmorphic disorder. Consider condition-specific management or referral to an appropriate specialist if a medical disorder or medication, including self-administered anabolic steroids, is likely to be contributing to a person's acne.